Good afternoon. My name is Dr. Lesley Northrop, the Chief Diagnostics Officer at Everly Health. I'm excited to speak to you today about at-home collection, removing barriers to STI detection and diagnosis. I want to thank LabRoots for inviting me to speak with you today. Before we dig into the testing capabilities, I would like to review STI's size and scope of the problem. The incidence of STIs, as reported in 2018, is 1 in 5 Americans. There are 68 million infections in 2018, and 26 million of those were actually new infections. It costs our healthcare system $16 billion in direct medical costs. Focusing specifically on HIV, and looking more at the scope of STIs in America, there were close to 1.18 million people aged 13 years of age and up whom had an HIV diagnosis by the end of 2019, including 13% of those were undiagnosed. Rates of HIV transmission, thankfully, was decreased since 2015. However, it continues to affect certain populations, starting with the highest prevalence from left to right. Men having sex with men, Latino and African American races, as well as young adults 20 to 34 years of age. HCV is the most common chronic bloodborne infection in the United States, affecting more than 2.7 million people. HCV is not only transmitted via drug use, but also can be transmitted sexually. In order from highest prevalence of disease, screening is highly recommended for people born from 1945 to 1965, men having sex with men, and people who are already diagnosed with HIV. With a high rate of infections also comes with barriers to detection. Predominantly, this is due to social problems, lack of education, and we're also dealing with a disease that is asymptomatic in its early stages. The majority of chlamydia, gonorrhea, and trichomonas and HPV infections present with no symptoms. More importantly, there's a lack of perceived consequence in young adults and adolescents aged 15 to 24. Per the CDC, education is the best way to prevent spread of STIs. As of 2020, only 29 states mandated sex education and only 16 require instruction about barrier methods. We truly need to start educating our population on the risk of STI infection. Additional barriers to detection are also come with social stigma due to socioeconomic factors that are not strictly clinical, such as costs, transportation to a testing site. Many of the highest risk populations are the young population from age 15 to 24, repeatedly noted as a testing barrier. With the socioeconomic factors, as mentioned, cost, transportation to a site, as well as provider availability, as well as scheduling is one of the key barriers to testing. Traditional point-of-care testing has a plethora of factors which lead to reductions in STI screening. Now that we've briefly gone over the scope of the problem, the barriers to a diagnosis, I would like to highlight a broad overview on traditional point-of-care testing. As represented here in the table, there are 3 unique ways of detecting risk of STI diseases. There's nucleic acid testing, or NAT, antibody testing, and antibody antigen testing, depending on the STI that you're testing for. Each of these testing methods comes with their own pros and cons. The traditional pathway of viral STI testing is screening via the antibody or antibody antigen testing first, and then any positive cases would require a follow-up nucleic acid testing for final diagnosis. There is no test that can detect HIV or HCV immediately after infection. The type of test performed can depend on the purpose of testing, such as screening with antibody or antigens versus diagnosis via nucleic acid testing, as well as the timing of exposure and/or symptoms if they arise. Some of the disadvantages to point-of-care testing may include access to the testing sites may require transportation to a clinic, sometimes long distances if living in a rural area with limited access to healthcare. Also comes the social stigma. This can reduce compliance with CDC screening guidelines, where individuals are concerned of anyone knowing whether or not they are positive for an STI. Also, there are some direct costs or lack of insurance that limit individuals from getting STI screening testing. I'd like to represent here a new pathway of STI testing. Instead of point-of-care testing, you can have testing within your own home. As represented here from left to right, I want to recognize the ease of access to testing. In starting on the left, an individual at risk can access their own testing and register a kit directly online. The sample is received in the individual's home, and the sample is collected by the individual in their own home, and once collected is shipped back to an associated CLIA/CAP certified laboratory. The sample is then processed under the same lab processes as if it was collected by a healthcare provider within a clinic and is sent to the lab, providing the same standard of care technology for the patients. The results are then reported back to the patient within 2 days from receipt of the lab, either via electronic transmission through our physician network, which also provides a consult to the patient in talking with a physician. Also, there's a personalized dashboard that a patient can log into and get the report. These access provides a high-quality testing under quality control checkpoints as provided here. We can also provide immediate notification via digital integration when the report is delivered in real time via our portal or through a physician network. In situations where there's not enough sample to process, the patient is immediately notified directly instead of having to go through the primary care healthcare facility, and we can immediately follow up with a second collection and provide testing options for the patient. There are also benefit comparisons of STI testing pathways. In here, we're representing traditional testing as well as at-home testing. On the left, traditional testing requires access and transportation to a clinic or a laboratory. It includes a doctor visit with a prescription and/or clinic fees, which can result in more patient expenses and time. Testing rates are affected by social stigma and privacy concerns, and sometimes can lessen the individual in receiving testing to begin with based on those barriers. Whereas at-home testing can remove those barriers because the individual can do the testing in the privacy of their own home. They don't have to transport to a clinic. They also don't have to spend the time by transporting to a clinic and can order the kit easily online and have the kit delivered to their home and do the testing within the privacy of their own home, which includes all the costs of the testing as well as telehealth consult with a physician network. This can also provide a lower burden on healthcare providers. Regardless of where the testing is done, whether it's in your own home or the testing is clinically collected and sent to a lab by a clinician, the same regulatory guidelines are followed. There are different definitions and examples, as well as regulatory agencies that oversee these different types of regulatory tests, such as IVDs and laboratory developed tests. An IVD is reagents, instruments, and systems that are intended for use in diagnosis of a disease or condition, where a laboratory developed test is actually a type of IVD that is designed, manufactured, and used within a single laboratory. Some examples of an IVD would be an OraQuick, which is an in-home HIV test, which is an antibody detection screening based test. Or you have the Everlywell HIV test platform, which is validated for self-collection within your own home via our Everlywell Partner Lab network. It's overseen by the Center for Medicare and Medicaid Services, as well as CLIA, where the OraQuick is overseen by the FDA. Analytical validity and clinical validity studies are important to ensure that these tests meet the test performance as required by the regulatory agencies. It is important to note and understand that at-home collection shows similar accuracy and precision, as well as test sensitivity and specificity for STI detection. Recent studies have shown that DBS, or dry blood spots, is a viable alternative for HIV, HCV, and HBV testing to in-person blood draws, with a 99.5% of samples testing positive for the viral surface antigens. As represented here on the right, this is a representation of a dry blood spot card on how you would collect the blood samples. At-home collection for other STIs, such as chlamydia, gonorrhea, and trichomoniasis, has been used in diagnosis in using a swab collection or a urine collection, depending on the sex of the individual. So how can we increase adoption and engagement to STI testing? Primarily, we can do it through community-based programs or outreach programs to help increase the screening rates for these diseases. Recently, a program in Florida has been launched where they paired viral STI testing with needle exchange programs. HIV, HBV, and HCV rapid tests are available free of charge, with confirmation testing as needed. Through this platform, they were able to show a 58% of HCV and 75% of HIV novel diagnoses were able to be made. This also initiatives seek to destigmatize testing and engage with at-risk communities by providing chlamydia and gonorrhea testing in a needle exchange program. So now that we understand the scope as well as the barriers to testing, let's dig into the at-home laboratory testing and show you the value and key drivers of success. Previously, in the last year, we represented a presentation at a meeting in which we showed data around the value in at-home testing for STIs. This study was real-world data from over 1,400 individuals with a negative test result. 416 of those were actually confirmed results with an in-person standard of care testing. Through this study, we were able to show high accuracy and consistency with samples that were collected by healthcare professionals for identifying people who truly did not have the disease. This demonstrated confidence in the performance of at-home sample collection for large-scale STI screening. As represented here on the right, you can see the accuracy of negative test results in comparing self-collected samples with in-person standard of care collection. For HCV, trichomoniasis, HIV, and syphilis, it shows greater than a 99% negative test result. In developing high-quality at-home lab tests, it's important to recognize that the same technology is used on clinically collected samples as used on at-home collection samples. The standard of care collection of clinically collected specimens tested for chlamydia and gonorrhea, nucleic acid testing, is the preferred testing method for diagnosing infections. As stated, this is the same technology that's run on patient-collected vaginal swab specimens with equivalent sensitivity and specificity as those collected by standard of care clinical collection. There are several testing technologies used for detecting chlamydia and gonorrhea on standard of care specimens as listed here on the left. As stated earlier, these same technologies are optimal for testing urogenital specimens types for screening by using similar nucleic acid testing, which include urine and vaginal swabs. Nucleic acid testing are FDA cleared for endocervical specimens from women, urethral specimens from men, and urine specimens from men and women. Some of these nucleic acid tests are cleared for vaginal swab collection. There's immense value in at-home STI testing in that the accuracy of at-home LDTs have comparable sensitivity and specificity as if the sample was collected clinically within a healthcare setting. Here's data showing you on the left chlamydia and gonorrhea collection of samples that were collected by a physician within a healthcare setting compared to samples that were collected at home. On the right, it's showing you the precision and accuracy of this testing methodology. As well as back to the left side of the table, you can see the sensitivity and specificity of the different types of samples that were used in detecting chlamydia and gonorrhea. and there was greater than a 97% sensitivity and specificity regardless of where the sample was collected within a clinic or at home by an individual. The value of at-home STI testing shows affordability and accessibility. The government has also endorsed some of these testing methodologies via a healthcare platform. The affordability allows at-home STI testing can be covered by some healthcare insurance providers and is already started in the state of California. The Affordable Care Act covers HIV testing and syphilis screenings for adults. It also covers for individuals who are less than 24 years of age, they can receive free chlamydia and gonorrhea screening. The at-home STI testing also allows accessibility. Kits can be shipped to the patient's home. It's a contact-free process that ensures privacy for the individual, and it's supported and guided and consulted by a physician expertise via telehealth platform. And some of these instances also involve a prescription for antibiotics in when an individual is identified as a positive. Since we have offered STI testing, we have released over 1 million results thus far. We continue to demonstrate a value proposition with at-home testing for STI screening. It's safe and reliable. It's affordable to an individual. There's true price transparency on our testing collection. It allows access to screening in areas where healthcare providers may not be available, but also in situations where an individual may be experiencing some barriers to testing due to stigma or age. It also allows convenience to testing as well as privacy to testing in the care of the individual's own home, as well as a result in the individual's privacy when consulting with a physician. At-home laboratory testing in the STI landscape provides a robust, fit for purpose, as well as early and frequent regulatory engagement process. It is supported via our physician network. Patient-collected specimens run on the same laboratory testing technology as used for clinically collected samples. It allows collaboration development of a regulatory approach to at-home sample collection, as well as an iterative engagement on evidence requirements building clinical utility. Thank you so much for your time.